And I think that at no point, even though I'm the person that helps coordinate the telemedicine program, is it my goal to make everybody do telemedicine all of the time. It should be an option for the right patients at the right time. And I prefer to think of telemedicine not as an entity, but as a way you could deliver care.
Welcome to RadCentral, a radiology podcast hosted by Excalibur Healthcare. I'm Laura.
I'm Betsy.
And Betsy's going to introduce our guests.
Sure. We have with us here today Judd Hollander, MD. He is the Senior Vice President of Healthcare Delivery Innovation at Jefferson Health. He is also a professor of emergency medicine at Sidney Kimmel Medical College of Thomas Jefferson University. Welcome.
Nice to be here. Thanks for having me.
Thanks for taking the time to speak with us.
Sure.
So I want to tell the audience a little bit about how I found you. You were on a panel of speakers at the Philadelphia chapter of the American College of Healthcare Executives annual meeting, and I was just I was very interested in what everyone had to say. I thought it was a great presentation. The title of it was Disruptive Innovation in Healthcare Delivery. And I knew that you were someone that I wanted to seek out to have on our podcast after listening to you.
I feel honored.
Can you tell us a little bit about your background and how you came to arrive at the position you're at right now?
Oh, I could kind of fill up the whole 30 or 40 minutes of this tape doing that, so I'll try and keep it short. I actually trained in internal medicine and emergency medicine, though only practiced emergency medicine, and got lucky at several points in my life. The first bit of luck is I sort of evolved rather than had any career path that was planned into doing emergency medicine research at a point when there wasn't really much emergency medicine research happening, and spent the early part of my career and the middle part and part of the late part of my career growing out a very robust emergency medicine research program, initially at SUNY Stony Brook, and then close to 2 decades at the University of Pennsylvania here in Philadelphia. And at some point, I decided that the skill set that was needed to be a really good researcher could actually have more impact being applied to strategy and operational development of a health system. And I jokingly say, a spreadsheet with a bunch of numbers deciding whether a drug works is really the same as a spreadsheet with a bunch of numbers looking at return on investment for new programs in the health system. So I went back and did, a reasonable degree of training through the Wharton program, did not get an MBA. I like to be clear on that, but went for some of their adult evening programs and some of their one-week courses. And I often say that people are better off getting skills rather than getting letters. And I made sure that I got the skills that I thought I needed to translate from a researcher to going into health system administration, and then moved from Penn to Jefferson at the time that Steve Klasko got here about a decade ago, and was lucky enough to be recruited along with several of my colleagues so that we were charged with starting a telemedicine program, opening a chain of urgent care centers, and helping to pull together some of the innovation that was part of his vision. And so that's kind of how I evolved to where I am now, loving what I do on a day-to-day basis.
For telemedicine, I understand that you were in the thick of it during the COVID-19 epidemic, and I did some homework, and I heard you speaking on another podcast about needing to kick telemedicine into high gear when COVID hit. Is that one of your largest, most challenging projects to date? I can imagine it was a pretty hectic time for you.
Well, it was a pretty hectic time, but it turns out that wasn't one of the most challenging projects to date, because I got lucky being, hired into a health system 5 years ahead of COVID with a plan to, at that time, reimagine. And I hate the word reimagine as much as I hate the word disruptive, because it's really about recreate. Imagination is good when you're in kindergarten. When you're an adult in a health system, you need to recreate and not just imagine. So we actually began and embarked on a very robust telemedicine program in 2015. So by the time COVID hit, actually all the pieces were in place. And what actually happened the first week when Philadelphia shut down in mid-March is we went into the film studio, and one of my colleagues who's moved on, Aditi Joshi, created videos on Saturday morning to train those people who weren't trained in how to use the technology that they already had usernames and passwords to. So we were clear on what we needed to do. We had the technology in place. We now had the blessing of being able to take all the naysayers and make them say, please, please, please train me as fast as you can. Mm-hmm. So it was really exciting, and it was a ton of work. And I had a team of 11 people that rotated out to get 2-hour naps while we got this done over a week and a half. But, COVID, as horrible as it was, made telemedicine grow nationwide. But we were in a really good position when it hit, and we were able to take care of 70% of patients that had scheduled visits the first week of COVID by converting them from in-person visits to telemedicine. It was a hugely satisfying experience.
That's wonderful.
Yes.
So if that wasn't challenging, what has been a challenging moment in your career?
Well, the biggest challenge is getting people to change their workflows and getting people to understand things that they don't think about all the time. So, for example, in the 5 years we were growing out telemedicine before COVID, we trained over 1,000 doctors, but we were lucky if we were doing 20 to 50 calls a day, because they just didn't see it as an important thing. And it was kind of annoying to have to learn something different when a lot of their metrics and a lot of their perceived value to a health system is about seeing patients in person. And so it was constantly, sort of headbutting. And Robert Rosenwasser, who long before I got to Jefferson created a neurostroke network with telemedicine, describes it nicely. Like, everybody thought we were crazy till they realized we needed this. And it was really, being able to grow it out in what I always say is a scalable and durable model. And so we started by saying, who wants to play nice in the sandbox? And some people did. And then we said, we need everybody to learn this, whether you're going to use it or not. And luckily, we spent 3 years having teeny weeny financial incentives for people, and this is really what they were before COVID. You needed to do 12 visits a year for half of the people in your department, or 20 visits a year for 20% of the people in your department. And there was accountability to the department leadership to do that. And some of them would complain. And I'm like, you know what 12 visits is? That's the afternoon of June 30th. Like, everybody can meet their incentive. This is not hard. But if a patient wants a telemedicine visit, it's our obligation of taking care of patients in the way they want to be taken care of. And you need to know how to do it. So it was really small numbers. But those really small numbers allowed a lot of people to use the technology and get comfortable with it enough that when we had to scale it up, it wasn't as big a problem as it was at other health systems.
Now that it's less of a necessity without the pandemic, are the numbers going down? Do you need to convince people now that another emergency could happen and suddenly we'd all be thrown into telemedicine again?
So it's gone down compared to COVID, because some people like to be in the room with their doctor and some doctors like to be in the room with their patients. And I think that at no point, even though I'm the person that helps coordinate the telemedicine program, is it my goal to make everybody do telemedicine all of the time. It should be an option for the right patients at the right time. And I prefer to think of telemedicine not as an entity, but as a way you could deliver care. So an example I often use is, we don't compare the cardiologist performance on the third floor compared to the cardiologist performance on the fifth floor, right? You want to see a cardiologist. So one way to see a cardiologist is via telemedicine. Not every patient wants to drive downtown to Center City, so they don't need to. They could do it on telemedicine. But if you want to come down, wrestle with the traffic, pay you $25 or $50 for parking and see your doctor, come on down. So I don't think we want to push any technology or any care delivery method on any particular patients or providers. We just want to create the most options we can.
That's wonderful. I did, and this was talked about at the panel discussion. You did take a question about someone that was concerned about access for different healthcare populations, and that seems to cover it, making many ways for people to access care. With all of the innovations that are happening, I believe the person at the panel said, should we be concerned that we are leaving some healthcare populations behind by continuing to innovate, possibly away from what some people are comfortable doing to get their care?
So I have a difference of opinion with the person who answered that question.
I remember.
Yeah. I kind of thought maybe I offended her, but I
don't think so. I don't think so.
Well, good. I think that we can't confuse healthcare equity with healthcare technology, right? We can't do that. Should everybody have access to healthcare? Yes. Does everybody need exactly the same access, exactly the same way? No. So again, it's the care I'm trying to deliver. So let's say you need to see a lung specialist, a pulmonologist. You should be able to see the pulmonologist, but we don't make it so everybody could get to the pulmonologist the same, right? Some people take a bus, some people take a car, some people walk, some people use video. Some people can't get on a bus for whatever reason. Some people don't have a car for whatever reason. Some people don't have an iPhone or a cell phone, smartphone for any reason. And that's okay as long as they can get the care they deserve. I fear, and this is one of my biggest fears, that some regulator's going to say, we can't use this on anybody because we can't use this on everybody. And there's nothing else in the world we hold to that standard, not a thing in the world. I brought a 35-inch TV the first year they were out. A whole bunch of people couldn't buy 35-inch TVs. We didn't ban 35-inch TVs. So we do need to deliver care, but we don't all need to deliver care the same way. The second thing that I want to add to that, the reason we don't have equitable care is insurance. It's not smartphones. It's not Wi-Fi. It's not everybody in the country. And I shouldn't even say insurance. It's our payment models. So right now, our payment model is largely based on somebody having insurance. And we, at many health systems, won't even let patients without insurance make an appointment if they promise to pay cash, right? So access and equity is not about a smartphone. It's about getting the right care. And the problem we have is how we pay for healthcare and that people are uninsured. It's not that they can't afford an iPhone.
So
you had a question.
My question to you is the telehealth that you developed at Jefferson, was it able to be, were any other health systems around the country able to look at what Jefferson did and then use that during COVID? Was it something that you were able to collaborate with other health systems?
So we did a lot of collaboration with other health systems at the beginning of COVID, largely with respect to training. So we had, again, already developed CME modules to train people on how to do physical exams. So we made them available to other health systems rather than just internally. And several thousand people took them the first month or two of COVID across the nation. Wow. Part of the problem becomes, as much as people think telemedicine's inexpensive, it's not. You need to buy a platform, right? These things aren't free. Just like we're going to use AI now. It's not going to be free. Everybody talks about how AI is going to make it more efficient for the doctor. Well, that's great. But if AI takes 10% of what the doctor makes, it's not going to make it more efficient for the doctor. The doctor's just going to have to see more patients, and AI is just going to add to the churn. And so telemedicine, people had if they weren't doing it somewhere already, it's really impressive how fast many of my colleagues figured out how to do, I'll call it a dumbed down telemedicine program. And because the government was quick, and I'll give the government a lot of credit for this, for putting waivers in place. So if you needed to do it on FaceTime, which wouldn't meet all the privacy criteria that we might want in a healthcare system, you had to do that because you had to deliver care. That actually was super problematic for us as much as it was super helpful for everybody else, because we had to wrestle with people in our health system that preferred to just use their phone with technology that didn't create the same degree of privacy as the technology we were contracted with.
Right.
And so for us, it was difficult because we had to put out multiple statements and multiple calls saying, you can't go off and do this on your own, even though your buddy over here is doing that, because we have a system and it maintains maximal privacy and provides all the documentation and checks the licensing to make sure you're in the right state of the patient. And just FaceTime doesn't do those things. Right. So I would say that the amount other people scaled up was surprisingly impressive. To me, we didn't do telemedicine expecting COVID to hit or any disaster to hit, but we were really well situated, as I spoke about before. It wasn't really an issue for us to scale. And many of our learnings were related to training and how to do it, because we couldn't help people buy a new product overnight, install it, integrated with their EHR and get going.
Is there an acceleration of new products for telemedicine that are based on the acceleration of AI being introduced everywhere? Or is telemedicine relatively unchanged in the past 4 years? Are people starting to come up with new innovations to what you were using 5 years ago?
So I don't think there's as much innovation in the technology as much as there's innovation in the use. And I'll give you an example. We, use telemedicine to see patients. Okay, big deal. We could use the video. We have a great video system that's integrated with our EHR. It's as smooth as could be. We could monitor how often there's problems with it. We could, proactively correct them most of the time. So, platform A to platform B, yeah, but there's not going to be a great innovation there, or there hasn't been since then. There could be. Where our innovation is recognizing what we could do that's better for our patients. So one of the programs that I'm proudest of is that our oncology service line launched a same-day, next-day cancer care program. So God forbid your family member is diagnosed with cancer. In our region where we provide care, we literally can see you today or tomorrow for your first appointment. And we could do that leveraging telemedicine. The telemedicine platform itself isn't relevant. It just gave us an opportunity to grow out a hugely needed clinical program leveraging the technology we used. And that's really what we're trying to do. We're trying to take better care of patients in any manner we can, and telemedicine is one of the manners. Now, if I'm a regular oncologist, I'm going to see X number of patients a day. Doesn't matter if they're in person or via telemedicine. So telemedicine doesn't let me expand the number of people I could take care of, but it did let us hire new people that could then see people from a broader swath of geography to help take care of more people, and know we could pretty much fill up their schedules right away, where that wouldn't happen if you had in-person visits only, because they have to come in. So it's strategies like that that I think is the next step of innovation, rather than changes in the platforms.
It's just increasing the amount of people who are able to use it nationwide.
Right.
Correct.
And what do people want? They really want 24/7 access to care. You're probably not going to make an appointment at 1 a.m. with your doctor. But when I was training in medicine in the 80s, actually at Mallinckrodt, and I know this is going to be seen by radiologists, they scheduled outpatient MRIs till like 2 a.m. Like that doesn't happen most places. Then they shut down the machine for a couple hours to get its obligated rest and cool down, and they were back running at 6, 7, or 8 a.m, right? The cost there's labor costs, which is obviously people. There's machine costs. But if you ran a building that you could make money in, the goal is not money, but you can make money or provide services in 24/7, but you only run it 40 of the 168 hours a week, you're leaving a lot of patient care opportunities on the table. However, you can't get enough people to run it exactly the same 168 hours a week. But with telemedicine, I can take working families where both spouses work and say, you stay home and get the kids off to school, and you'll work 12 to 8 p.m. And I don't have to find an MA willing to work at 8 p.m. or a nurse willing to work at 8 p.m. We can still have you see your patients at 8 p.m. So a lot of our, in fact, all of our same day, next day programs require 12 hours a day during the week and some Saturday, Sunday hours, so we can expand access to the patients. And we could do that meeting economies of scale because we leverage telemedicine to do that. So I think telemedicine has become a way to provide the care we all know we always needed to provide, but itself, it doesn't provide care.
You talk about the challenges for telemedicine in training the staff at the hospital. Were there any challenges that arose with just the general population learning how to use the program?
Yeah.
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 I mean, how do you address those?
Yeah. So, that's actually really complicated because there's clearly people that are going to be, very intuitive and people who are not going to be. And so we've taken a variety of approaches that range from when it was early pre-COVID, calling people the day in advance and doing a test call with them. And we had people that we called telehealth coordinators, and they would reach out to the 20 patients who were scheduled tomorrow and do a practice test.
Oh, wow.
Then we've tried embedding things in the appointment reminders that say, don't do this, don't do this, don't do that. And simple things, many of the telemedicine platform, if it says your doctor's going to be late, what do? You go on the web and you find a YouTube video. Well, now if you're on YouTube, your telemedicine video may not work. And you don't know that you shouldn't be doing that. So there's a lot of messaging that we could put within the body of the email that someone may or may not read. But then there's a lot of, it's actually training the doctor to be a little bit tech savvy, and say, oh, shut off the video and then I could hear you better. Right? You've all done that on Zoom. Somebody can't hear you and you turn down the video and you could hear better. So we have to teach everybody a little teeny weeny bit of technology to make the patient experience better. But the other thing is there will be patients, this comes back to the equity question Betsy asked earlier, there'll be patients that can't use it. They're 95, they barely could see. My dad was one of them when he was 90. But that doesn't mean it's not easier for my sister who lived near my dad to go over his house and do a telemedicine visit than it is for her to go over his house, pick him up, take him to the doctor, wait forever, drop him off. So I think in the early days, we thought too much about the individual and we weren't smart enough to think about the caregivers. And so we could still deliver better care via telemedicine to people that can't even begin to do telemedicine on their own because they have somebody around who could help them with it.
I'm going to switch to a leadership question. As the Senior Vice President of Healthcare Delivery Innovation, where do you seek out the best ideas for new innovation that you can introduce to your health system? What habits? What are your leadership habits for finding and implementing change that benefits patients? So
my piece of advice is look outside of healthcare. Healthcare has groupthink. You can take me out of Jefferson and pop me in another health system, and a large part, not all, but a large part of the conversation will be exactly the same as to how do we do this, how do we do that. And so going back when I was taking my additional classes, in the business end of things, I never took one taught by somebody in healthcare. In fact, I searched out the classes that had the fewest people in healthcare in them. And there's one class I use an example a lot. I took a class, I think it was called something like Finance for the Non-Financial Manager. It's like 25 or 30 people in a 1-week course or a 4-day course in the room. The head of the Nigerian banking system was in the class. The
Wow.
person in charge of IT for all of South American Marriott was in the class. The CEO of a pharmaceutical company was in the class. Who is not in the class and not teaching the class were CEOs and leaders in health systems. And so I did. That was at the time I was transitioning from Penn to Jefferson. And they're like, who wants to give an example of a project? And I knew I was going to have to start a telemedicine program. So I had these guys informing what they thought I should be doing with a telemedicine program in 2014.
Mhm.
And I went back, probably a couple of years ago, but a long time after I grew the telemedicine program and said, let me find my notes from that day. And, I don't remember how much I remembered from that day, but we had done all the things that these people had come up with. And so to me, I'm kind of always on in how can I make a connection between A and C if there's not a connection. But the most important thing for me to know is where are their problems? Because I often get pitched, here's a cool idea. And I don't care if it's a cool idea if I don't have that problem. I need to know what my problems are. And if I know what my problems are, I may be able to find something that could be a solution, even though I was never looking for it.
Yeah. It's a
Okay.
lot like marketing. You find the pain
Yeah.
points, right? And then you have to fix them. It's
Yeah.
simple.
I'm
Yeah.
going to RSNA in December. It's the largest gathering of medical imaging
Yeah.
professionals in the world. So there's going to be no shortage of cool ideas and no shortage of lots of people trying to get my attention to see if I have problems that their cool new ideas can solve. How can I cut through the noise while I'm at a trade show and subjected to thousands of exhibits? How do should I start with my problems and go
Yeah.
looking for answers? Okay.
Yeah. And I think if someone comes over to you and says, we have this great thing, the answer is, can you solve A, B, and C with it? So I know what problems we have, and I know why they're hard to solve. So I often get told, recent thing, we'd like to provide care for patients in Arizona, and this platform could do that. I'm like, was this platform going to help my docs get licensed in Arizona? Is it going to get them malpractice in Arizona? Is it going to set up the right business entity and tax IDs in Arizona? Because otherwise, all you're doing is creating a lot of hassle for my legal teams. And how many people in Arizona want to have a doctor at Jefferson? Right? That they're going to see only via telemedicine and never come in person. And then what does your product cost? So I've learned, and this may be true in the radiology world, maybe not. Everything you're going to do costs money, right? It's incremental money. How much ROI does it really bring in? Right? So let's say I could buy something for $100 and they say it's going to bring me $150. Right? Wow, that's $50. But now I have to bill for it. I have to appeal the bills. I have to integrate it into the radiology machine. I have to integrate it into Epic. I have to hire someone who does that. And by the time I'm done, I've spent $80. So I'm paying $100 to make an extra $80. That's moronic. So I think that we have to know that the companies are selling. Here's what we charge. Here's what CMS pays. But we have to know what are my extra expenses, because otherwise you can't begin to do the math. So I generally am walking around with, what problem do I need to solve in my background? And I am very much a skeptic on everything, and I am straight up a skeptic on everything. I'm like, before I even have this conversation, you answer me these questions. Do you know how much it costs for my integration into the EHR? No. Well, then don't tell me I can make money. And sometimes they know. And those are the really useful companies. And then, have you funded any research? Yeah, and then how could I help you? Your company's not perfect, you know that. What do you need from me? And how could I make that translate into something that gets me a steeply discounted price so we could help grow something out together? And those, being in the world of innovation gives me the opportunity to do that. Having a research background and bunches of publications in nice places gives me the ability to do that. But, everything is a trade-off. And I think that we need to understand where their pressure points are and how we can help them get better. Because almost all the people that are at these trade shows either have a well-oiled product that you're going to use or not, or they're new and you need to figure out what's the best way for you to do a deal with them.
So there's a nationwide physician shortage, and particularly in radiology, we deal a lot with recruiting radiologists. Is this something that you have considered a problem that you're trying to solve in disrupting healthcare?
Yes, if you could make new radiologists, I would love
Just
that
make them.
problem to be solved. We have that, but you know what? But why is there a radiology shortage is problem number one. Problem number two is how do I deal with it while I have the radiology shortage? So we do a lot of tests. I don't know the real numbers. You might. What percent of those tests are negative, right? I don't need those readings right away, but you better find my aortic dissection right away.
Right.
So there are companies out there that will have AI jumping the critical findings to the front of the pile so the radiologist could read them sooner. If it takes you 2 weeks, I mean, God forbid, and this is a bad example, to get back a mammogram that's negative, that's really different than if it takes 2 weeks to get back a mammogram that has scary findings and needs further testing. No woman should have to wait 2 weeks to get the results back because, you know, it's an anxiety-provoking thing anyway. But what we have to do is make sure we don't miss badness. And so I think we need to figure out how to utilize the tools we have, in your example, radiologists, to make sure they're doing the most critical things as a priority, and leave the less critical things for later.
Yeah, and the use of AI is really going to come in handy over the next forever, right? Just using the technology that's being developed. Is that something that Jefferson is working on implementing?
So AI is a challenge, but yes, AI can be implemented in multiple different ways. Like in the corporate back offices where it's lower risk to patients is easier. We've actually tried AI into my chart messaging. This is fascinating because doctors, it's just a time sink. It's an uncompensated time sink. They do most of it from home. You know, handling the inbox is a horrible burden, but needed for patient care. So it turns out that if you let AI into the inbox, it doesn't write the message the doctor would write, right? It's actually so funny, the example
I think
we
I've
had.
experienced this.
You might have, but you know, one of our doctors, I'll let him remain nameless, was one of the people that was dying to try this, and they would write, the patient would write, "Can I have a refill?" and the doctor before would write, "Yes," or "I'll call it in."
Sure.
And the AI wrote, "Oh, it's coming up on the holiday season. How are you feeling? Have you thought about gifts for your family?" And that might be nice for the patient to receive, but since it never goes out with the doctor having to review it, the doctor now had to review all these niceties that slowed down their workload. And literally, this one doctor did the prompt engineering to say, "Please don't be as nice to the patients, just be polite," because it was just taking more time to read the AI things before he can hit send.
Right.
So I think we got a ways to go in the non-radiology world. I think, you know, finding a lesion on an x-ray and jumping it to the front of pile is probably great. It's not the world I live in, so I don't know its performance characteristics, but I think radiology is probably going to pave the way in clinical AI.
When I go to the RSNA, I know that there is a seminar or an exhibit. I wish I knew a little bit more about it right now, but I know one of the needs that AI might serve is that as a patient, I can see my report from a radiologist before the referring physician is able to call me or let me know what the report says. And it's confusing. And what I know that there's AI in the works to interpret a radiologist's exams so that the patient that happens to get to their report on the My chart is able to at least understand the basics of what they're seeing. So,
I think that's great, but I would ask the question, like, why is that necessary? Why can't the radiologist write, you can discuss this with your physician, but there's nothing that's emergent here at the top of the report, you know, and do that. Because I think one of the projects we're wrestling with now is how to take better care of the non-English patient. Right. And there are standards. So you can't just use AI to translate anything. You need medically qualified translators, which often means that nothing gets translated. Right. It's another one of these things. I need a medically qualified translator and I don't have one. So I send them back their discharge instructions in English, which they don't read. Like, which is worse, that or using AI that probably gets most of it right and then gives you a number to call and discuss it where a translator could be there. I think we need to, you know, reinvent how we do this. But if we're going to use AI to make up for systems that are dysfunctional rather than fix the dysfunction in the system, we're just going to make it more complex.
Are there any other projects that you can speak about that you're working on there at Jefferson?
You know, increasing access. As you know, we just did, when I got to Jefferson in 2015, we were a 3-hospital system. We're now over 30 hospitals with a recent merger with Lehigh, which is great because Lehigh is a really mature system. And one of the things I'm working on is, you know, integration between the places as it pertains to telemedicine specifically. And you know what? They evolve differently than us. So there's things they have that are brilliant that we haven't even started to do. And today we have a very well-oiled project that we're very proud of, that we presented to them for them to do. And they ask questions about, can you make it do this that we never thought of? And the company's like, yeah, we could do that. And so I think one of the things I've learned is that the more people you try and get in a room, the longer it takes to get them in the room and the slower the project goes. But what I'm evolving to realize is there's a sweet spot at which the wisdom of the crowd is really important. And like a lot of it is, I don't like to make perfect the enemy of good. I'm an ER doc, right? I need to act right away on most things. I don't have tons of hours to make decisions. That's the way I manage as well. But there comes a point at which probably need to step back more and get new eyes on a problem, because then there's just the wisdom of the crowd does better than individuals every time. And I'm getting to take advantage of that and enjoy that. In sometimes I'm taking a look at something they have and sometimes they're taking a look at something I have, and we're all better for it.
Yeah, just considering different perspectives is always valuable.
Yeah.
I've enjoyed all of your answers. It's clear your enthusiasm for your work is benefiting thousands of people.
It's very interesting.
Hope so. That's the goal.
Yeah.
Was there anything else that you would want to cover or address in the podcast?
No, I think we actually evolved to most of it.
Okay.
Well, anyway, it's a pleasure meeting you guys and chatting with you.
Yeah, thank you so much for taking the time to speak with us and share all of your wonderful insights.
And the most important thing in conclusion is go birds.
Go birds.
Yes.
I almost got on in an Eagle shirt.
Okay.
All righty. Well, have a great day.
Thank you.
All right.
Thank you so much.
Thank you.
Sure thing. Bye-bye.
I loved hearing him when he spoke in the panel discussion, and I just thought it would be so interesting to get on the podcast and be able to share some of his comments with the audience.
Yeah, I really like his openness to collaboration and just keeping an open ear to everybody, right? He doesn't just learn from other healthcare executives. He's learning from, what did he say, the owner of the bank in Nigeria?
I think that made a lot of sense, that to be creative, you have to get yourself out of the environment you're in and expose your problems to other people.
Yeah, it was great.
Take us out of here, Laura.
RadCentral is a production of Excalibur Healthcare. Thank you for listening to our podcast. Like and subscribe wherever you get your podcasts. From all of us at Excalibur Healthcare, have a great week.